Hello everybody. We are here today to talk about altered passive eruption. Today we are dealing with a case of type 1 subtype B. As we can see, first of all we have to deal with oral hygiene. So the first phase of treatment will be to reduce inflammation as much as possible. Then when the patient is ready for treatment, as you can see, we're going to measure the difference between the anatomical length of the teeth on the X-ray and the clinical length of the teeth in the mouth. We have to assess the amount of keratinized gingiva and possibly know that we're not going to remove keratinized gingiva and create any kind of mucogingival problem in this kind of patients. Using a tunneling knife, we will actually design the flap, keeping in consideration the position of the CJ of the teeth that we have evaluated in the X-ray. We perform internal beveled incision with a 15C blade, keeping the blade possibly as close as possible to the CJ of the teeth. Once the incisions are completed, we remove the collar of soft tissue with a curette and we expose the original anatomy of the teeth. We can see with the use of a curette how to remove the collar of tissue that is covering the enamel of the teeth. We can see the beautiful natural anatomy being exposed, and the patient has already a new smile before flap elevation. After this, we proceed with elevating the flap in order to evaluate the biologic width around the teeth. As we can see in this case, the bone level is located exactly at the cement enamel junction of every single of the teeth of this patient. For this reason, it will be necessary to perform osseous resective surgery to create 1 or 2 millimeters of gap between the CJ and the bone crest to assess a new biologic width. Full thickness flap is elevated about 3-4 millimeters above the CJ, and once hemostasis is there, we proceed with a round diamond burr to create the scallop new anatomy surrounding the teeth. This is the shot before osseous resective surgery, and by using the burr as like a brush, we gently remove 1 or 2 millimeters of buccal plate, and by keeping a positive anatomy, so the interproximal bone more coronal compared to the buccal bone, we create grooves in such a way that the gingiva can reposition itself in the interproximal spaces once the surgery is completed. The movement of the burr, as you can see, is very gentle and delicate. We thin the bone in the buccal aspect, creating nice scalloped anatomy, and paying attention to repositioning the gingiva in the most passive way possible. The sutures at the end have just to keep the flap in place without any kind of tension. Now we can go back with the periodontal probe and measure the biologic width that we have achieved. The same thing is done in the second quadrant. The burr is applied to the bone without using any kind of pressure. And especially on this upper left canine, you can see the bulkiness of the bone that needs to be thinned in order to be able to reposition the flap in the best possible and passive way. You can see that the burr actually flattens and cuts through the bone horizontally first. Once this procedure is completed, we go back with a bigger burr just to polish and refinish all the corners, and we can see that now we have a beautiful new anatomy and biologic width. With a back action scalpel, we just polish the small edges in every side of the teeth so that we have a perfect place for attachment, so that the connective tissue can actually reattach in its normal and natural position. As you can notice, now we have a brand new biologic width, and the soft tissue can actually adjust with single interrupted sutures, possibly placing the knots in the palatal aspect for aesthetics with a resorbable kind of stitch. We can see the beautiful adaptation of the soft tissue at the end of the procedure and how the enamel, the natural enamel of the patient, is completely exposed, giving our patient a beautiful, bright, natural smile.